So start with that. A 17-year-old girl came to our clinic, okay, with the complaints of headache and eye strain, blurred vision after 10 minutes of reading. Okay, so uncorrected visual acuity was 6/6 in both eyes. Retinoscopy and acceptance, it was plus 0.5 in both eyes. Okay, so with that, the patient could read 6/6 with plus 0.5 diopters in each eye. So the girl's complaint was headache, eye strain, and blurred vision after 10 minutes of reading. Okay. So now let's, when we check the near point of convergence, it is 7 centimeters. When we have done the cover test, distance it is ortho, and near it is 2 prism base out. Okay. So 2 prism base out means there is a isophoria of 2 prism. Base in it is, when we have done the NFV PFV testing, base in for distance it is x 7 and 4, near it is 8, 20 and 12. Base out for distance it is x 18, 10, and near it is 6, 18, 10. Okay, so what is the normative values for the, yes, am I audible to all of you? Am I audible to all of you?
Yes, ma'am.
Yes. Okay, okay, fine. So what is the normal value for this one? For base in for distance? What is the normal value for base in for distance? It is x 7 and 4, and near it is 8, 20 and 12, right? Base out for distance was x 18, 10, 6, 18, 10. Okay. So the normative value for base out for distance is break at 11 and recovery at 7. Base in for distance, it is 7 and 4. So base out and base in, what was is there any value, the value was proper or not? Base in for distance, it is showing that break at 7 and recovery at 4. So you can see almost the value was quite okay. Okay. Base in for near, that is break at 13 and recovery at 10 and plus minus 6. So it is also, base in value is also okay. Now base out for distance, the normative value is break at 11 and recovery at 7 plus minus 7. So base out for distance was a little bit more. Okay. And base out for near, the break is at 19 and recovery at 14. So base out for near is also, yes, it little means almost okay, right? So the base in base out value, that means the PFV and NFV value was quite okay for the patient. NPC is 7 centimeter, but the patient was complaining of headache while reading and all, and eye strain while reading. Now coming to the AC by A ratio, that is 6.8:1. NRA was also quite normal, that is plus 2.5 diopters. Okay. And PRA was little bit abnormal, it was only -1. Okay, it was only -1 diopter. So PRA value was quite less. Now let's come to the accommodation part. Amplitude of accommodation was both eyes like 7 diopter, 7 diopter, left eye 7 diopter, right eye 7 diopter. Monocular accommodative facility was 0. Binocular accommodative facility was also 0 cycles per minute. MEM retinoscopy, it was plus 1.5 diopter. So what may be the diagnosis and management? What may be the diagnosis of the case? What do you think? Yes? Anyone would like to try? What may be the diagnosis? Yes. See, NPC is 7. NPC is quite normal. Headache, eye strain, blurred vision after 10 minutes of reading. Vision is 6.6. OS, OD 6.6. Okay, right? Plus 0.5 retinoscopy we have found out. And cover test, if we found out there is near 2 prism esophoria. Okay, AC by A ratio is 6.8:1. Okay, so that means a higher AC by A ratio. Now there is 2.2 esophoria at near. So if the student was having plus 0.5 in retinoscopy, so would you like to give the plus power to the patient? Yes or no? What we have got in retinoscopy, plus 0.5 for both eyes, and the patient accepts and reads 6/6 with this refraction. So would you like to give the full, would you like to give this correction to the patient? Yes or no?
Yes, ma'am.
Yes, why? Yes, why?
Because of Can we prescribe plus to correct the esotropia?
Okay, very good, very good. See, okay, very good. See, the AC by A ratio is 6.8:1. So what does it signify? If we can give a plus 1 to the patient, it will correct how much amount of esophoria? 6.8 diopters of 6.8 prism of esophoria will be corrected. Now near the child was having, the patient was having 2 prism esophoria. Okay, so if we are giving, we have got a plus 0.5 in both eyes. So if we are giving a plus 0.5, so around 3.4, so around 3 prism esophoria will be corrected, right? So that problem will be solved for the patient. The patient esophoria will be corrected if we are giving a plus length therapy to the patient. Okay, now see that what is the thing, the base in and base out value, those are all normal. That is, the Vargin's parameters are quite normal. NR is also normal, but the PR is very less, -1. That means the patient is having difficulty with the minus lenses, right? Amplitude of accommodation is also quite less. So what should be the amplitude of accommodation for a 17-year-old patient? So 18.5 minus 0.3 into age. Yes. How much should be the amplitude of accommodation for the 17-year-old patient? So let's calculate and see. 18.5 minus 0.3 into age. 0.3 into 17, it is coming to be 5.51, right? So 18.5 minus 5.1, it comes to be 13.4 diopter. But see the amplitude of accommodation here. It is only 7 diopter in the right eye, 7 diopter in the left eye. So don't you think the amplitude of accommodation is very less? Yes or no? Yes?
Yes, ma'am.
Right. So the amplitude of accommodation is very low. Also, the accommodative facility is 0. Binocular accommodative facility is also 0. Why? Because see this PRA value, it is only -1. So if we select the +-1 clipper also, the patient cannot clear that -1. That means the main, and also if you see the MEM value, the dynamic retinoscopy value, that also if you see, it is coming to be plus 1.5 diopters. So normal lag of accommodation, what we should have, it is a plus 0.5 to plus 0.75 diopter. So there is a higher lag of accommodation. So here we can actually diagnose the case as a accommodative insufficiency, because the accommodative parameters are quite less what is required. And also the dynamic retinoscopy value is less, higher lag of accommodation is there. Okay, we are getting also a low PRA value. Okay, whereas the Vargin's parameters are quite okay. So what should be the management for the patient? We should give this plus 0.5. Okay, because if you are giving this plus 0.5 in retinoscopy, So what we have got? So it will release the phoria, the esophoria of the patient. Slight esophoria the patient is having. Okay. Also, the patient, if the patient is having accommodative insufficiency, that means the patient is having a problem at near, problem to work at near, right? So if we can, if he is having a this thing, no, like a latent hypermetropia, so any kind of latent hypermetropia should be corrected, right? So if we correct the latent hypermetropia, what will be the benefit for the patient? The demand for accommodation will also become less. Okay. Also at later ages, the patient will not get that is a like pre-presbyopia condition, the patient will not be getting, and also it will help her in accommodation. Okay. So this esophoria part is taken care of. Now PR is only -1. So what should be the management for the patient? So it is a clear-cut case of accommodative insufficiency. So what should be the management for the patient? Any guesses? Any cases?
Can you repeat? Because the sound was not audible.
Yes, I'm just asking what should be the management. It is a case of accommodative insufficiency. So we'll give plus 0.5 refractive error correction in class. What else will do for the patient? What else will do for the patient? We need to give her.
Ma'am,
Yes.
yes, we can give weakest convex lens, or
Yes.
we will prescribe 0.5 for the near.
No, for distance and near both, the patient 0.5 will work well, because for a 17-year-old girl will not give a addition, right? Will not give an addition.
Yeah.
So plus 0.5 will prescribe for distance and near both. So the patient will use that
Yes,
glass
yes.
for distance and near both. And what kind of
And
accommodative
accommodative
exercises? What kind of?
exercises. Yeah. Yes,
Yes,
exercises we can give.
yes. So exercises definitely we can
Uh,
give. So what are the accommodative
yes.
exercises? What we need to give? What kind of exercises we need to give? Like, can you? Heart chart exercise. Have you heard about heart chart?
Yes, we can give heart chart
Yes,
exercise.
Yes. We can give heart chart exercise, definitely.
Accommodative. Yes.
Accommodative
A
flippers.
kind of accommodative test charts.
Yes. Accommodative flippers we can give. Accommodative flippers definitely we need to give. Yes. So first we will, if the patient, see, the patient cannot accommodate at all. Accommodation is less actually, not accommodate at all, but accommodation is less. So what we'll do, we'll try to stimulate the accommodation. Okay. So we'll give her the plus 0.5. So it will help her in accommodation. It will really like reduce the accommodative demand a little bit. It will correct the esophoria also for near. Okay. So along with the plus lens therapy, we will give the patient to do the heart chart exercise. So at first when the patient will be doing the exercise, the patient will find difficulty in doing the exercise. Okay. Slowly the patient will improve. Okay. So once the patient improves, we'll start with the flippers exercise. We need to give the accommodative flippers also. Why? Because you can see the accommodative facility is completely zero with the ±1 flippers. So we can give the in-office treatment of accommodative facility, like accommodative flippers exercise. We can give it to practice in our clinic. So first we'll give the heart chart exercise, we'll give the glasses, we'll give the heart chart exercise to do, we'll see how the patient is improving, and then we'll give the accommodative flippers exercise to perform it in our clinic and see how the patient is improving. Now the patient could not clear those minus lenses, -1 at all. Okay, so slowly it will improve. Now if you check the PRA, it will also improve. -1, it was -1 previously PRA. So when the accommodation is improving, the PRA will also improve. What else will improve? Also the higher lag of accommodation also will come down to normal lag of accommodation. That will happen. Accommodative facility will improve, and also the amplitude of accommodation will also improve. So we need to monitor this patient for long, because the patient is having accommodative insufficiency. We need to monitor the patient and see how the patient is improving.